So I want to talk a little bit about my journey. So I asked that question about, do we have any experience in here with neuropsychology or brain injury? Because I think most of us are psychologists in here. So when I came to my neuro rehab program, I was coming off losing my postdoc. And mind you, I'm going to rewind back to internship. I didn't match my first year. So psychologists know if you don't match your first year, it's like, oh my gosh, what's going to happen in my life? And then having a postdoc all lined up and then having to move to Maine, that was my kind of journey to Maine here. That my husband and I were going to work for the same place. We're both psychologists, and I was going to start at the same company, and that company went under in the last economic downturn. So I had no experience in brain injury, no postdoc options. I mean, this was like the only one. So I think it was divine intervention that I do this work almost. So part of my journey was okay, well, I'm just going to have some energy and like pump Beyonce in the car and like really hope for the best here on this postdoc. And I ended up getting the position, which I was ecstatic about. And I was dumbfounded because I really didn't have much training. However, they really wanted someone to do therapy. And so, they said often they get people who are more interested in neuropsychology who just want to do assessment after assessment after assessment and aren't as interested in therapy or in groups or anything like that. So they wanted someone with my training. And I think what stuck out to me about that was just how little training I had coming to that program and just lack of resources for the population. And their pain, it seemed like, was so significant. So it was just a massive time for me to look through all kinds of information related to concussion, to neuropsychology, and to really just understand the pain of the people that were before me. And if you guys have questions, you can certainly put those in chat as we go along. Okay. So what we're going to go over today, just let me move you guys on the screen a little bit, is understanding brain injury a little bit. I thought that I needed to do this because I didn't know how many of us had any formal training in brain injury. So it's just like a baby snapshot into brain injury. And some reasons for therapy after concussion or brain injury, some statistics, various modalities, and importance of referrals and early intervention. Okay. So, acquired brain injury is the umbrella term that we consider for brain injury in general. So, that would include those that are non hereditary, congenital, degenerative conditions such as Alzheimer's or other like MS would be not an acquired brain injury. And essentially, this type of brain injury is one that occurred after birth. So, ones that occur before birth are congenital. So that's what we consider with an ABI or acquired brain injury. So sometimes you'll see that terminology of ABI for acquired brain injury. So two types, non-traumatic and traumatic. So non-traumatic is things that can happen where there's not a jolt to the brain. So that would be like a stroke, aneurysm, lack of oxygen, so an anoxic injury. Sometimes there can be lots of reasons for lack of oxygen to the brain, like if someone had a heart condition, a heart attack, and then they didn't have blood flow, so then they didn't have oxygen to the brain. That's one reason why someone might have an anoxic injury. And traumatic brain injury, or TBI, is defined by having an external force, and traumatic impacts can be penetrating or non-penetrating. And so examples of those include falls, assault, motor vehicle accidents, sports, and shootings. Yeah. Okay. So just want to have you look at this graph a little bit here. So this is representative of TBI and those that presented to the hospital ER. What do you kind of gain from this graph?
This seems relatively common, I suppose.
It is. It is. It's relatively common. It's happening all the time. And this proportion of people is around 300,000 people struggle. That's 15% of these with long term problems. So it's not a unique injury. It's something that deserves a lot more attention, and I think especially from mental health providers. So, how do you receive the diagnosis? So, I was going to talk a little bit. I'm not going to talk too much about the Glasgow Coma Scale or how you look at that, but just briefly, it's a scale where they'll get up to 15, and a 50 score of 15 on a Glasgow coma would indicate full consciousness. So, I'll just go to the next slide so it makes a little more sense. So here are your classifications. So we have three types. We have mild, moderate, and severe. So mild would be a 13 to 15. So people in the mild category are conscious. They can talk to you. They pretty much know what's happening. And the loss of consciousness is LOC. So I use an acronym there because it's really long. So you often hear this talked about in concussion as well. Loss of consciousness for mild TBI is less than 30 minutes. Most of the time with concussion, we don't have a loss of consciousness. So why that's important is it's important in other categories of TBI. So for moderate and severe TBI, we're going to look more at the loss of consciousness because it might be indicative of more symptoms. So for moderate, you're going to have the coma scale 9 to 12. So that things on that scale are like, can they open their eyes? Do they like respond to pain? Those types of things. Okay. Severe would be 3 to 8. They're kind of non-responsive, and loss of consciousness for greater than 24 hours. Those or people would probably be in a coma. Okay, so DSM-5 criteria is that they are met for a major or mild neurocognitive disorder. I didn't put those criteria in here. You can look that up in your DSM. There is evidence of TBI. So either they have blunt trauma or acceleration and deceleration of the head. So they've had, I don't know if you guys have heard this term, of a coup and a counter coup in the head. So the head is sloshing towards the skull and away from the skull. And that jostle in the brain is the acceleration, the deceleration, where we see injury and concussion. So you can have one of the following: loss of consciousness, post-traumatic amnesia, and sometimes you will see anterior grade amnesia as well, which is amnesia before concussion, disorientation or confusion, and neurologic signs. And then it presents immediately after the occurrence of brain injury. So you're going to see those signs come up. Although there can be a delay in concussion. So just because someone is not symptomatic after concussion doesn't mean that they're not going to be symptomatic. It's important that we just continue to watch folks after concussion. Okay. This is surprising to me. So most of the time I think when we think TBI, what do we think of? What's the first thing that you think of? You can put those in chat or shout it out.
Accidents.
Accidents, right?
Car accidents in particular.
Mm-hmm. Yeah, but especially in Maine, there have been so many cases of people who have fallen on the ice. So I have like ice picks and I walk like a penguin now because I'm so scared of slipping on ice because of the people that I treat. So I think just being aware of that, especially for our aging population, more often than not, for concussion or a TBI, you're going to see someone with a fall. And that's very common. So just to be aware of how they happen, and certainly motor vehicle accidents, sports injuries are part of that. For younger folks, we don't see that as much. Sports injuries aren't going to be a big cause of TBI for older folks. And I think especially with more training that I've had to do recently in domestic violence, I think we all had to do that for recent licensure requirements. Assault is 9% of TBIs. So if you have someone who has a history of abuse, I think it's really important that we're assessing for concussion as well. We're assessing for cognitive symptoms. Any questions on that? Okay. So 75% of brain injuries are considered mild. And I'm going to say mild because we're trying to actually get away from the word mild TBI because the symptoms are not mild. So people can not return to work because they have a mild TBI. They, lose functioning in many areas because of symptoms related to a mild TBI. Estimated cost $17 billion per year. and imaging from CT or MRI do not show changes. So there's no structural change to the brain with a mild TBI typically for concussion. You don't need to have a loss of consciousness. And I remember in my training, actually, my supervisor would tell me, like, sometimes it's actually better for them if they had a loss of consciousness because the trauma response is reduced. So they don't remember the event and then they're not being re-traumatized by thinking about that event anymore. So I found that interesting. I couldn't find a study that talked about that, but I think just clinically he would often talk to me about if someone remembered their injury or if they didn't remember their injury and how their presentation was. Okay. So how we think of concussion is a neurometabolic cascade. So there's no structural changes typically. We have axonal shearing. So the neurons actually, when they're jostling forward and back in the head, they shear. So that means that they're not functioning as well. The cells aren't functioning as well. So what we see is all kinds of things happening in the brain after concussion. So you can see this pointer. Yes, you can see me doing that. Okay. So this is glucose. So glucose is reduced down here. Any ideas what we need glucose for brain function? In general? Energy, right? Our cells need energy to be able to make those connections, to work properly. And another thing, another chemical that's interesting is increase of calcium. So calcium inhibits energy use. So there's all kinds of things. We have reduced ability to get energy in the cells, and we have things that are inhibiting the energy to be created, if that makes sense. Again, I'll refer you to this study. I am not a biologist because there's so many things that I don't even understand. But I think if generally we think of there's an energy deficit in the cells, and that's what's happening with concussion, I think that can be helpful for treatment. Okay. General, I'm just going to check my time. If I'm flying through here kind of quick. Question so far? I'm just looking in chat. Energy for cells, yes, thank you. I'm seeing that now. All right. So 80 to 90% of concussions heal on their own, which is great. That's positive. That's wonderful news. I think a lot of times we are so scared because of that recent movie Concussion that came out about, football and multiple concussions and that you can get dementia. And I think people are just scared. So one blow to the head, most of the time you're going to be fine. So I think if we can kind of get that message to our clients that, okay, if we don't know anything, let's just kind of make sure that you're getting the things you need to heal and following concussion protocols. And I think our job is really to instill hope, to make sure that we're kind of helping them with anxiety, with depression, and just kind of referring them to their providers to make sure they're getting the management they need for the concussion.
When you say heal, do you mean like return to baseline?
Yeah. So if we're thinking of that energy crisis, so all of those ions and neurochemicals in the brain, when they're healed, they go back to baseline. So if we're thinking that's when a concussion feels healed, when my energy crisis is over, that's the goal. Does that make sense? Okay. So general protocols are saying a brief period of initial rest, 24 to 48 hours only. So before they were saying for concussion folks, no screens, no light, 2 weeks, stay in the bed, don't call and And what are some ideas about what that can cause? If we do that to somebody, tell them no screens, no contact, don't do anything, no exercise.
Social isolation and boredom.
Yes. Especially routines as well. Let's see if anybody
Depression.
Mm-hmm. Yeah, so increased depression, social isolation, it's important to think about. So every several years, the Berlin Consensus Statement comes out on concussion. And the most recent one This is a quote from the most recent consensus statement. Persistent symptoms do not reflect a single pathophysiological entity, but describe a constellation of non-specific post-traumatic symptoms that may be linked to coexisting or confounding factors, which do not necessarily reflect ongoing physiological injury to the brain. So let's unpack that a little bit. What does that tell you? I'll let it sink in for a second.
Is it suggesting that all of the symptoms are not attributable to the physical injury? It could be other things like the trauma, like PTSD symptoms, say.
Right, right. So we're not seeing anything on imaging. So there's other things that are happening. So metabolically, there's things that are happening. We're thinking about that energy crisis. A lot of psychological reasons that can be impacting their recovery. Yeah. Let's see if there was anything in chat there as well. No. Okay, so we need multimodal clinical assessment that's required to identify specific primary and secondary pathologies that may be contributing to persisting post-traumatic symptoms. Okay, and some typical symptoms that we'll see. So they're going to fall into these buckets. So physical, bothered by light or noise, dizziness, a hallmark of concussion a lot of times that we see, headaches, nausea or vomiting. Early on, I don't really see people struggle with nausea. Well, with the dizziness, yes. So vestibular symptoms, you often will see that, and vision problems. So interesting thing about the brain, a large part of our brain is really firing for vision. So if we know that, then of course vision is going to be implicated with concussion because there's diffuse injury all over the brain. So a lot of times that's why vision is implicated. Cognition, attention, concentration problems, feeling slowed down, foggy, groggy. Thinking clearly is often a problem. And I think with mood, sadness, we talked about that, just what can happen if someone's isolated, they're just going to be pretty sad. Sleep is often another one, more than usual, less than usual, or trouble staying asleep. So rest is not best. That is pretty much the consensus. So bed rest surpassing 3 days is not recommended, and a gradual resumption of pre-injury activity should be started as soon as tolerated. So if we think about, I don't know if anybody's had surgery recently, and you don't have to tell me your medical history or anything like that. But what are some general surgical recommendations when we have inflammation in the body? What are people telling us to do? Stay in bed for days and days and days? We're supposed to move, yes. So movement more quickly. If you've been in the hospital, they're trying to get you up and moving more quickly. And that's the same thing with a concussion. We want to get somebody moving as quick as possible. So I'm not going to go over this in detail. So these are general steps for concussion management. So step 0, and this is for children. So you might see different criteria for adults. And this is for athletics. So return to sport, return to school. So baseline is rest. They don't attend school, limit screen time, inform school of injury, no sports, roughhousing. The younger the athlete, the more conservative the treatment. So you might be in these steps longer for younger ages. So generally these steps are going to take about 24 to 48 hours per step. So we're not saying okay, you've rested, you're not getting better, so continue to rest. We want to progress someone on the steps. And if they're getting stuck in their recovery, then we want to refer them to people that can help them get unstuck. So our next step would be light aerobic exercise. So we're trying to increase the heart rate, which is going to increase blood flow. We want to increase the blood flow because we know cells need more blood flow because they're not getting them. So that's going to help with inflammation. So 5 to 10 minutes. And so PTs will help them with toggling their exercise. At its most extreme form in the nervous system, you'll see someone with something called dysautonomia. With dysautonomia, they have exercise intolerance. When they exercise, their heart rate goes crazy, or when they sit to stand, their heart rate goes crazy. So someone with those symptoms, PTs would work with them on, toggling that exercise back. But generally, if we're letting them rest for too long, we're going to increase exercise intolerance. So when they even try exercise, they're not going to be able to do it. So moving through these steps as quickly as tolerated is important. And if they get stuck, then we need to get them help to get them unstuck. So resuming school, full to half days, rest at home, limiting screen use, and step 2, avoiding the bus, no tests. Then we're going to increase exercise. We're going to increase cognitive load in step 3. And if they do well with that, in step 2 rather, in step 3, if they're doing a sport, non-contact exercise, so maybe drills without contact, more specific sport drills, and they can attend school full time. And then if they're playing, then the final step would be return to competition. But they would need to go through all those steps, make sure they're meeting those criteria. Make sense? Okay.
Typically these recommendations are coming from a primary care physician,
They are.
right? Yeah. Okay.
They are, or if you have someone that's doing specific concussion management, so PTs could also do this. OTs typically don't do this. There's some chiropractic neurologists that can do this. Yeah, typically a medical provider, you would be looking to do the concussion management piece. Yeah, but I think it's important for us to know if they're getting stuck, we need to make sure, okay, well, the PCP maybe isn't helping them get to the next step. So do they need to go, to somebody else, another provider to help them with exercise intolerance or whatever it may be? Any more questions there? No. Okay, we kind of alluded to this before. What are some problems with prolonged rest? I'll just go over some of these. So exercise intolerance, I've been talking about that, mood symptoms, the nocebo effect, which is really quite interesting. So we think of the placebo effect as, okay, I'm going to give you something, a sugar pill, you're not actually getting the treatment, and you're going to get better, right? We don't think about when we tell someone, like, for an antidepressant, we're going to tell them you could have these side effects like weight gain or, increased depression. So they found that people, if they are hearing harmful effects, will start to feel those harmful effects. And I noticed this a lot in concussion and brain injury that they will start to believe, if they haven't gotten relief of symptoms, that the treatment is not going to be helpful. And they also did some research finding that the provider installation of hope, or their comfort with being able to deliver that treatment, has a big effect on this. So us being able to say, you know what, hey, most people recover from this. Most people tolerate this. We have to provide informed consent, of course, but we also need to weigh that with, are they able to have some hope and see that they can get better? Because if they don't believe they can get better, they won't. Psychologically, they're going to be stuck in that mindset. So, okay. Relational isolation, I often see, and you can ask me any questions about that. I just read that research and I was like, oh my gosh, this is amazing that we don't often think of the nocebo effect. Somatic fixation. So they really get fixated on, I'm not sleeping. Like, I slept 4.5 hours last night. And I'm like, well, what were you sleeping before the concussion? Oh, maybe 5.5. Okay, so let's look at the difference between those two things, because they're going to feel really heightened with those symptoms. They're really there, but I think their anxiety and their depression regarding their symptoms really do impact them as well. Fear of falling behind. So for a student or for anyone who maybe has missed work, they're going to be fearful of falling behind. Okay. All right. So I took this definition of psychotherapy after brain injury. There's a book that Klonoff had written about that. It's mostly about moderate or severe TBI. Her experience was in neuro rehab. I've primarily, since my training in neuro rehab, have mostly seen mild TBI, concussion. I've also seen a smattering of other people after a brain injury, like stroke, toxic mold, chronic Lyme, different issues here and there. But I like this definition. So it's a collaborative working relationship between a psychotherapist and a brain injured patient with the goals of increasing self-awareness, acceptance, realism about their predicament. And so we're educating. A big part of my job is education. So what can you expect from your brain injury symptoms? What can be helpful? What are things that you can do? How can I empower you? Supporting the family is very important. So I find a lot of times when I see them in outpatient and their primary issue is concussion or brain injury, they've probably been struggling with that for quite a while, months or years, and their family is fatigued. So if we're talking about a couple, they're often pretty estranged because the other partner might have been the caregiving partner, and then it's hard for them to figure out these new roles and like, how do I pull back and how do I help support my partner? Yeah. And I think this last part, identity, hope, and meaning, has been what I acknowledge is the most essential part of the work. Oftentimes they see that as there's been a point before my injury and a point after my injury, and I've been completely changed. And how do I create a new identity now that my life is so different, for people that are struggling with post-concussion syndrome or significant effects after brain injury? So brain injury therapy has been understudied and previously thought contraindicated. So many times in rehab, they thought, oh, if we give them therapy, we might make them worse. We don't want to highlight their emotions. We just want to kind of calm them down and not really talk about it. We know what that can do, right? But not acknowledging pain, not acknowledging emotion just creates more of a barrier. Difficulty with defining brain injury and concussion. So, their brain injury is runs the gamut. You have one concussion that looks one way and you have another concussion that may look another way. So the treatment, I think, it needs to be fairly individualized because of that. Stigma with concussion and mental health symptoms. I think a lot of times after an injury, they get to the end of neuro rehab or the end of cognitive work, and then someone might tell them, well, I think you need to go to a therapist or get some psychological treatment. They're like, what? This is a concussion. This isn't psychological. So in their mind, they're getting all this physical help or cognitive help, and then someone kind of telling them it's in your head. I've heard that so many times from so many people that, a doctor told me it's in my head. I mean, I don't know what was told to them, but that's their feeling. So if they're made to feel it's in my head and there's nothing I can do, I'm just going crazy, that's really, really hard for them. So I think a lot of understanding the course of concussion, understanding how they can get better and how mental health is so involved in their treatment is essential. Okay. I'm cruising along here. I'm just checking my time again. Okay. Just pause for any questions, see if there's any. You can unmute. Just throwing a lot at you. I'm letting your brain absorb. Everybody has resting presentation face. That's okay.
Something I'm wondering about is, and maybe you'll talk a little bit about this later, but I've had a few folks who have other kinds of physical health problems, and I think it can be really hard for them to distinguish between sort of increases or changes in symptoms that might be benign or even good, the way that like when you exercise hard, you might be sore the next day, and things that they need to sort of watch out for as an indicator of like something might be wrong. And I think people tend to err on the side of putting too many things in that category of something is wrong versus that, like, I'm sore after exercise. And I'm wondering if those ideas come up for you, and kind of how you help people navigate that.
Yeah, with regard to exercise or just like any
Just resuming activities and feeling sort of impacts from it.
right. Yeah. I mean, I think, they might initially have gone out in their early part of their injury. A grocery store is a common trigger. So if we think of all the sensory information that we need to process when we go to the grocery store, there's like someone overhead, there's all these sounds and sights, and there's so much more visual space. So if we know that vision is an issue in concussion or in brain injury in general, them having this difference in that space is going to trigger symptoms. So if it triggers symptoms, I feel pain and I don't want pain, I'm not going to go to the grocery store. It makes logical sense. I think I kind of conceptualize it like panic. If I'm going somewhere and it's making me feel these emotions that are really uncomfortable, why do I want to do that again? When the cure is part of the symptom, right? We need to encourage them like we do with anxiety treatment. I know it's uncomfortable. It's going to be harder in the beginning. But I've seen that if you push yourself to the next step, that you're going to get better. In the long run, you will get better. And I think the sell for that with the client is hard because they're thinking that I am going to damage something or there's something physically wrong with my brain because of my concussion. And I think reassuring them that there's not anything physically wrong, but we have to manage this because your brain's still healing metabolically and functionally. Does that make sense? Okay.
I just want to say it does make sense, but it seems like the lay understanding, and I would include myself in that category for concussions, is that this idea that, like, if you push too far, then you feel symptoms and it's time to back off. But it sounds like you're normalizing that's part of the healing process.
Yes, it's part of the
Okay.
healing process. And so there's always going to be an energy deficit. So it's about the push and the pull. So okay, my baseline is here right now after concussion. Well, I'm going to try to get that baseline just a little bit more next week, and then a little bit more. So we don't want to push them so far. I think of like in a trauma context in their window of tolerance. We want to grow the window of tolerance so they can eventually do more, but it's not going to be someone who's non-concussed. But the idea is that we want to avoid all things is not helpful for symptoms either. Does that make a little more sense?
Got it. Thank you.
Yeah. So anger. Sometimes I see people and it's their primary presentation. They are just mad, mad at themselves, sometimes mad at other people. I see that more with frontal lobe injuries, but I have seen it in concussion as well, where people are just tired of their recovery. They're tired of providers telling them stuff. And so we work through a lot of the anger. One book I love is Andrea Brandt. I went to her presentation for Mindful Anger, is probably one of my favorite anger resources. I don't know if you guys have seen that book, but she's an EMDR consultant, which I'm EMDR trained. So I love her conceptualization of anger, and I've used it with clients. Mood symptoms, anxiety, depression, panic, trauma reactions. I often treat PTSD and concussion or brain injury clients. So I'm treating the actual injury. That's where their trauma came from. So I think it's overlooked. They don't, doctors don't say like, oh, you have PTSD. And when I look at the criteria, they meet all criteria, but that's been overlooked in their brain injury treatment, which is a big deal. Big deal. I could go into depth into mood symptoms. I could probably talk for an hour on that, but I won't. Maybe for another time. Anosognosia is a lack of awareness of symptoms. So sometimes with some injuries and also different diagnoses, we'll see that with schizophrenia and bipolar disorder sometimes where people aren't aware that they have symptoms. You might see that in various brain injuries. So a lot of times with frontal lobe, you'll see it socially, like they don't understand they're being inappropriate. their cat calling me as I'm on the rehab unit. I'm walking down there and they're whistling. And, I think working in neuro rehab, it kind of comes to the territory, just kind of ignore it and move on, or, we have to address it because they just don't have awareness regarding the social emotional behaviors. Relational difficulties, navigating new roles and understanding social dynamics can be a challenge. So, I've seen a number of different roles where someone, they've trained all their life. They were a mathematician and now they can't do kind of basic math, or they're learning how to kind of put silverware in the drawer. And it's really challenging for them to feel like I was at this place and now I'm here. It's a hard, I think, balance for them to figure out how to navigate that. Cognitive changes, they vary by injury, but we don't see, even on neuropsychological data for concussion, we don't see a lot of changes, which is maddening to some people because they're like, but I have attention issues. But when we test them, they test normal a lot of times. So, I think just working with them on their attention, even if we're not seeing it, it's really important because they're functionally not able to do it and struggling with it. Fatigue is huge. So managing your energy, thinking of the window of tolerance is what I think about. Okay. I'm going to show you this picture. This is a drawing that somebody drew, and this is public domain. I didn't put the site up here, but anyway, it's public domain of someone before their injury and after their injury. I just wanted to see what it kind of brings up for you guys.
My first reaction was that it seemed hemispheric, like the two sides not really communicating.
Mm-hmm.
What came up for me is that I don't really understand it. And I think that kind of speaks to how, like, the lack of understanding I have in seeing someone else's perspective of what's going on in their head and how their perception of the world might shift as a result of their injury.
Yeah. Just looking in chat, just in case. Yeah, I think it highlights that before and after. Like there was a time where I had to stop. So like the word stop there, that life is no longer like this. And even the chain kind of makes me think of how a lot of times people will say they feel a little shackled by the injury. So a lot of heavy emotions that I work with in the brain injury world, it reminds me a lot of trauma work. And it is trauma work for a lot of my folks. So I wanted to talk a little bit about trauma and TBI. So this is a graph that I made, and this is from the VA Center. So there's a lot of criteria that are shared between MTBI and PTSD. So fatigue, sleep problems, attention and memory, depression, anxiety, irritability. TBI is going to look a little different in that typically we don't see headaches and dizziness, nausea, light or sound sensitivity. Although sometimes I feel like my trauma clients would have some of that, vision changes. When I think when I first heard about PTSD and TBI and how they share some criteria, someone, I think it was a psychiatrist, was saying that a lot of times it's like the brain has a certain threshold. And I could see that in some of my clients, that maybe they had trauma from the past and they were able to kind of contain that. They never received treatment on their trauma, but after the concussion, it was like everything comes flooding back because their resources are really depleted. All right. So in a lot of ways, this is a big, you guys have probably seen the polyvagal stuff before, but I'm just going to go over it a little bit. So if we think about brain injury, a lot of times clients are here in the yellow zone. They're in the fight or flight zone. So heart rate is up, blood pressure's up, decreases in fuel storage, digestion goes down. So a lot of people have problems with their gut. because of that. We see that often in folks with trauma as well. So a lot of emotions, this is what I'm dealing with: rage, anger, irritation, frustration, panic, fear, anxiety, worry, and concern. Like, I'm not going to get better. Nothing's going to be helpful for my brain injury symptoms. So a lot of the work they do is trying to get them in that social engagement system. So if we're talking about the vagal nerve, which moderates our sympathetic and our parasympathetic nervous system, we're trying to get them into the parasympathetic. So in the parasympathetic, we're digesting food. We are healing. So our brain can heal in this zone. Oxytocin is released. Oftentimes my dog co-treats with me, because when I work with clients with brain injury, just petting the dog can really help calm their nervous system. So in our social engagement system, we're curious, we're open, we're mindful, we're in the present. All skills that you all have to help clients who might be struggling with brain injury. So a lot of modalities that can help with that are trauma therapy, mindfulness-based interventions, relaxation interventions, that we're trying to calm everything down in the brain, which is going to help them heal. So what we're trying to avoid is the freeze response. So keeping them away from the shame, shutdown, depression, where the heart rate goes down, muscle tone goes down, actually attunement to the human voice, which I found very interesting when we're in freeze mode, that we can't even hear the human voice as well. We don't hear prosody. So when we're in our social engagement system, we hear prosody in the voice. We're able to hear the natural rise and fall. So it's just interesting, I think, that when our bodies are in this state, we can relate more, that we can feel more calm. Just gonna check the chat. Yeah, okay. Any questions on that? Have you guys all kind of seen this chart or learned about polyvagal at all? There could be a whole training on that as well. Okay. And my little overview of that is, so stop is that parasympathetic shutdown. So your body will shut you down if you get too stressed out. And I see that a lot with brain injury folks, before they can push through and push through and push through. And then they're like, oh, I was researching something for work, and then my body just shut down. I'm like, yep, it will. That's your parasympathetic nervous system. When it gets overloaded, it will shut down. The gas pedal is on, so we're kind of pushing the gas. We're in our sympathetic. It feels active. We're moving. We're able to do something. We're trying to respond to that threat, and it's safe to go. We have safety in our parasympathetic nervous system. That's our play, rest, digest, and play is twice. I'll fix that. All right. Check the time. Okay. I want to have some time for questions.
I have a question.
Yeah.
I find polyvagal theory really interesting. I haven't had any formal training, but I've done some reading. I'm just curious, do you use handouts or do some psychoeducation with the clients you work with so they have this kind of conceptualization?
I do. Yeah. Oftentimes
Okay.
I'll show that chart, or I'll go back and I'll show that simplified stoplight for them, because sometimes that other chart is like way too much going on. But if I just say like, hey, these are our general responses to stress. And with a brain injury, those become more pronounced because we have fewer resources. So I'll give them some psychoeducation on that and how mindfulness-based interventions can be helpful in the nervous system, because we know that a lot of times folks after brain injury will stay in sympathetic. We're going to have more sympathetic dominance in the body. So we're going to try to increase the parasympathetic. And I think, oh my gosh, the book is like right there. Deb Dana, I like her book.
Deb Dana.
Yeah. She also has a flip chart, which I didn't include in references in here, but she has a really nice flip chart for client explanation. I'd recommend that. And she's a Maina.
I know.
Yeah. Okay. So there's some pretty good evidence for CBT, although, I would love to say after a brain injury, I could just give you a thought record and call it a day, be on your way. But I have not found that I use CBT a ton unless I'm talking about like, okay, we have, there's some pretty clear anxiety that I'm just going to want to target And I have done that. I'm not saying that I haven't done that. But a lot of times I'm thinking through the nervous system and I'm thinking, okay, I'm going to give you some skills to calm everything down, engage the parasympathetic before I can go cognitive with you. Because if you don't have your brain online, I don't know if you guys have taken Dan Siegel and his hand model of the brain, and if our emotional structures are in here and our frontal lobe, our CEO is here, we flip our lid. This isn't online. Cognition is not online when we're just an emotional brain, right? Okay. Installation of hope. I just want to highlight that nocebo effect can be part of prolonged symptoms after concussion. EMDR. So I'm an EMDR clinician. I do use EMDR with my clients to treat trauma. There's some preliminary, evidence that that's going to be helpful. There's not a ton, honestly, but I just think, what do we know about trauma? How are we treating trauma? And then taking that with concussion. So I don't do the eye movement. So with eye movements, I would be saying, notice that, follow my hands with eye movements. I don't do that with concussion folks because their eyes can jump around. They have vestibular issues. I can make them more symptomatic. So I use TheraTappers or I had even one client, she would do the butterfly hug and she would just kind of like stroke her arms. And that was her bilateral stimulation. That was how she calmed her nervous system. So it really, I think it takes being a little creative sometimes to figure out like what is the best mode of healing for this client. Grief and acceptance. I often feel like, I'm a trauma therapist and I'm a grief therapist with brain injury work. So talking about their personal losses and how they can incorporate those into a new identity. So referrals. So what we want to think about, and I meant to put this box on top, but we want to think about concussion management first. Referrals will be to the client's PCP most of the time. Reassurance, brief rest, and tapered but quick return to activity is best. So for someone that's not going to get stuck in that recovery for their concussion management, we're right here in this category. We don't need to do anything else. That's it. Leave it alone. Concussion treatment. So I'd recommend PT for exercise intolerance in the short term. Chiros with functional neurology perspectives potentially as well could be a good referral. So I wouldn't go up. I'm going to say we're going up the ladder now. Okay. Those interventions didn't work. Maybe we'll go up here to neuropsychology. Because with concussion, especially, we're not seeing, deficits usually. Like maybe they're going to be reduced from before, but we probably don't have a baseline. If you're talking about an adult, if you're doing impact testing, you might have that. So let me go back for a second. So with kids and for athletes, you might have had impact testing. So you might know where they were before and where they are now. With adults that I typically treat, I don't have that data. So they are telling me I have a perceived reduction in my abilities, but we don't know that. They're not necessarily deficient or under where they need to be. So it's just, I wouldn't say right away would I refer them to neuropsych. So cognitive rehabilitation, I would think this would be after, maybe the last step. I'm thinking more concussion treatment here with after the acute, and we really want to think about treating the head, the neck, and vision. So the people that treat head, neck, and vision would be someone who does functional neurology, who would incorporate concussion management together and working on the neck. Whiplash is important to think about. Vestibular system is important in vision. Just checking. I don't want to keep you guys too long. Okay. So I have a little thing I'm going to show you beyond this, but kind of lastly, Viktor Frankl is one of my favorite authors. So those who have a why to live can bear with almost any how. And I think that is a lot of times our job, having them find their why, figuring out that they can get through this, and then they can deal with the how they're going to do it after. I have a whole bunch of like referral ideas of people in Maine that I typically refer to. I was going to make that in a nice little referral sheet. I could do that for you guys too. I just kind of threw that up there because I was tight on time. But these are some people that I will refer to. Goodwill Neuro Rehab, shout out to my postdoc, great folks over there. Portland Chiropractic Neurology, and I feel like they do some concussion management too. And I'll have you guys look at that. Neurooptometry, if there's vision issues, neuropsych testing, and then my services. You can find me here. My podcast is launching soon. So it's coming on the 15th. So it's called TBI Therapist, and I'm going to be interviewing folks in this world and also survivors on how they've gotten through their injury. All right. So thanks so